Hello, High Guru community. I did a lecture on acute urticaria, and I myself wanted to look a little bit into antihistamines because I know it's common practice to use Benadryl. So let's do that. Here's the case. You have an 18-month-old female, again, like we did with urticaria, itchy, waxing and waning urticarial rash for 2 to 3 days, mild URI symptoms, no allergies, new exposures, or systemic symptoms. You treat with loratadine or Claritin in the morning and Benadryl, diphenhydramine QPM, and it works, of course, because this is wheal and flare, typical for hives. And it responds to antihistamine. So what is the most likely diagnosis? We know that's acute urticaria. What is your recommendation regarding her treatment choices? Which of these was correct? Was it the Claritin or the Benadryl? So of course, here's a basic science integration. How many histamine receptors do we know about and what do they do? There's actually 4 histamine receptors. The 2 that we most commonly think about are H1 and H2. H1 is the one that mediates allergic inflammation. H2 has to do with gastric acid secretion, but it's also involved in vasodilation. That's the reason why it's used sometimes synergistically with H1 blockers when we're dealing with allergic reactions. And there's H3 and H4. H3 is involved in neurotransmission and H4 in immunomodulation. So let's briefly review what H1 receptors do. So there's your histamine. It binds to an H1 receptor and it causes all sorts of systemic things: bronchoconstriction, vasodilation, pruritus, increased vascular permeability. Remember that anaphylaxis or severe allergic reactions affect 5 different organ systems: skin, respiratory, GI, CV, and neurologic. So in the skin, you'll see hives, flushing, edema; respiratory, rhinorrhea, voice change, wheezing, rhonchi, and rales. In the GI system, you'll get nausea, vomiting, and diarrhea and abdominal pain. Cardiovascularly, you can get hypotension, syncope, and tachycardia, and you can get altered mental status neurovascularly, as well as anxiety and seizures. Couldn't help the opportunity just to review some basic stomach or intestinal physiology when it comes to acid release from the parietal cells, which are located in the body of the stomach. Remember, there's the fundus, the body, and the antrum. There's your parietal cells. Remember that there are 3 primary things that facilitate or that stimulate the release of hydrogen chloride or acid in the stomach, and those are acetylcholine, right, from your vagus nerve there. That's histamine. These are H2 receptors, remember? So there's your histamine. And then finally, there's gastrin, which actually works on the chief cells as well. Okay, so here's our quiz. What is an inverse agonist as opposed to competitive antagonist? So it's important to know that antihistamines are actually just not basic competitive antagonists. They are inverse agonists, meaning they bind to that H1 receptor and they don't just block it. They don't just antagonize the effect of the agonist, of the H1 of the histamine. They also exert the opposite effect by suppressing spontaneous receptor signaling. So actually H1 receptors have tonic activity, tonic pro-inflammatory activity. So H1 receptor blockers decrease that baseline pro-inflammatory activity. What is the primary difference between first and second generation antihistamines? And this is critical. All right. First generation antihistamines are liposoluble, meaning that they cross the blood-brain barrier. They're going to have a neurological impact. They're going to cause sedation, drowsiness, and decreased attention. They're also nonspecific. They don't just work on H1 receptors. They work on serotonergic, cholinergic, alpha-adrenergic activity as well, causing dry mouth, nausea, vomiting, diarrhea, constipation, ureatension, polyuria. Remember, that's tons of small urinations throughout the day, increased appetite and tachycardia. Hydroxyzine in specific is dangerous in kids under the age of 2, as it increases the risk of prolonged QT and torsades. Remember, hydroxyzine sometimes used as an anti-itch, sometimes used as a soporific, as a somnolent to help kids sleep, particularly dangerous in kids under 2. Don't forget that. That's a first-generation antihistamine. How long after taking loratadine or cetirizine should one wait before the skin prick allergy test? You get this all the time. Kids with allergies tend to be on these medications and they want to go for allergy testing. There needs to be at least 7 to 10 days off those medications prior to skin prick allergy test. Why is cetirizine as opposed to other second generation antihistamine BID dosing? Well, that's because it has increased hepatic metabolism, and so therefore it has a decreased half-life. You can use it more than once a day. All right, actual clinical uses for antihistamines are few and far between. So there's a few of them. Allergic rhinitis, definitely. So kids with seasonal allergies, but really it's only effective in early non-severe seasonal allergies. So if a kid has itching, some sneezing, some rhinorrhea, then oral antihistamines and intranasal steroids are good. If you already have inflammatory congestion, meaning a kid has real nasal congestion, not just because of SNAP, but because there's swelling inside of there, then antihistamines are a great adjunct, but intranasal steroids or azelastine, intranasal azelastine, which is an intranasal antihistamine, are the real medication medications of choice for allergic rhinitis. Urticaria, we talked about this in our prior lecture. So hives, use second generation, not first generation antihistamines, and you can use up to 4 times the dose. The rate limiting factor there is if it gets the kids tired or not. Sometimes they need increased doses of antihistamines, and use it continuously, not PRN. And don't forget to taper off when you're dealing with urticaria, because you can get a rebound effect if you stopped them too quickly. Other things, and really here's some potential adjunct uses. So you can use antihistamines as an adjunctive trial, maybe for atopic dermatitis to help with itching. Definitely second generation and not first generation. Most studies say that it's really ineffectual for itching in atopic dermatitis, because histamine is not what mediates the itchiness in atopic derm. It's other chemical mediators. And asthma, well, if you have allergic induced asthma, if that's the trigger, then antihistamines, you definitely want to attack the origin of the symptoms. So antihistamines and intranasal steroids will reduce asthma aggravations and exacerbations, definitely. In anaphylaxis, epinephrine first. It's definitely not the first medication you're giving. If a kid has hives or skin manifestations, you'll give them a second generation antihistamine. Maybe consider using an H2 blocker as well for synergistic effect. But anaphylaxis, the rules number 1, 2, and 3 are give epi first. It has no clinical place. Antihistamines, do not use them. Do not mollify parents and make them happy by giving them for URIs, nonspecific cough, otitis media externa. Sometimes I see this given because it'll dry out the middle ear. Well, maybe if the kid has allergies and it decreases swelling in their nose and their ears can drain, but in general, it's not going to clear the middle ear space, and don't use it for sinusitis. No clinical indications in these circumstances. All right, first generation histamines. Let's get to it. Benadryl, does it have any role? The reasons not to. It's poorly selective, right, on H1 receptor action. It also has serotonergic, it has alpha-adrenergic, so it has neurologic effects. It causes sedation and cognitive impairment, especially Benadryl and hydroxyzine. You're at risk for overdose, and you're concerned for neurologic and cardiac side effects. So neuro side effects, CNS depression, seizures, and coma. It can cause arrhythmia and especially prolonged QT. Hydroxyzine in kids under age 2 is especially dangerous. Possible but not preferred clinical uses for H1. Definitely don't use it for allergic rhinitis or urticaria. Maybe for insomnia, but actually melatonin is preferred. And remember that H1 blockers, first generation, they actually distort sleep architecture. So the kid might fall asleep, but they're not necessarily getting good sleep. In terms of motion sickness, I see it used a lot. Behavioral intervention is actually the first line treatment or management for motion sickness. A backup would be Dramamine and Benadryl, but you go to your behavioral stuff first. Make sure they're seated in the proper position, no meals beforehand, stuff like that. In terms of appetite, I do see cyproheptadine used in kids greater than the age of 2. That might be the one circumstance where I see legitimately a first-generation antihistamine used. Okay, just an obnoxious chart that I made, which I will put into my Substack with the algorithm of uses for H1 blockers that goes through the most common second generation antagonists. Remember, they're inverse agonists, and then adjustments that you make for kids with renal and liver disease. Thanks for coming. Just a few things to review. As always, this is the review article that I used. Histamines and H1 antihistamines celebrating a century of progress. Great article. Get the evaluation algorithm as I usually do. I'll post it on my Substack page. Remember that there is an entire general pediatrics course covering well-visited acute care and newborn care that is coming soon. It'll be large, 82 lectures, comprehensive and clinically oriented. And then, as usual, if you have feedback or comments, please reach out to me at pediatrics@HighGuru. See you at the next lecture.